Okay, so welcome to the next module. This module is starting on chapter 27, and then it's going to be chapter 30 and 31. And we're going to talk about cardiovascular diagnostic tests to begin with, and some therapeutic procedures. Okay, so like the other modules, there's going to be just some topics that I'm going to talk about at the beginning, and then we'll go into them in more detail. Now, I know the two respiratory modules were quite long. I'm going to make an effort to reduce the length of time for the following modules, okay? So hopefully you get lots of information out of this. Okay, so let's just talk about a few topics first, and then we'll get into the module, okay? I find if we just do a review of some of the terms, it helps understand the module much better. Okay, so cardiac enzymes, what are they? Well, we do blood tests to see if we can detect cardiac enzymes in the bloodstream. And if cardiac enzymes are elevated in the bloodstream, it means there's been some kind of myocardial injury. Okay, so whether that's a myocardial infarction, a heart attack, or inflammation of the muscle of the heart, say myocarditis, which is just inflammation of the heart muscle. Typically, we're using cardiac enzymes to diagnose a myocardial infarction. Okay, so what kind of cardiac enzymes do we rely on typically? The most common cardiac enzyme that we use now is troponin. Okay, by far, it's the most common cardiac enzyme. And if someone comes in with chest pain, we're going to take blood for a serum troponin. And if it's elevated, because it's such a specific test, that indicates that there's been myocardial damage and an infarction, either an end-STEMI or a STEMI. Okay. Now, if someone comes in with stable angina or unstable angina, do they have elevated troponin? No. If someone comes in with an arrhythmia, an irregular rhythm, and we do a blood test, the troponin is negative, have they have a heart attack? No. Okay, so usually an elevated troponin signifies a heart attack. Okay, we used to use different cardiac enzymes. We used to use creatine kinase, CK. Okay, and that was a marker that we would use, creatine kinase, and MB was the cardiac portion of creatine kinase that we have in our bloodstream, and that type of creatine kinase was released from heart muscle. Okay, we don't use it very much anymore. Okay, we really use what's called troponin T or troponin I. Okay, and usually after a heart attack, these typically start to rise in 2 to 3 hours, and troponins can stay elevated for about 7 to 14 days. Okay, so even after someone's had a heart attack and they come back a week later, we may still be detecting an elevated troponin in their bloodstream. Okay. Creatine kinase, the older one, sure, it also goes up in a heart attack, and it typically only lasts about 2 to 3 days in the bloodstream. There was another one that we used to use called myoglobin, again, just another enzyme released by the heart, and that would be elevated in a heart attack, and it would only stay up for about a day, 24 hours. Okay. So really try to focus on troponin as the most important cardiac enzyme. Okay, I'm not really sure why cholesterol is bunched in with cardiac enzymes, but cholesterol is just a risk factor for heart disease, just like it's a risk factor for strokes, because elevated cholesterol is a risk factor for developing atherosclerosis in the arteries of your body. So whether it's a heart attack, a stroke, or peripheral vascular disease, elevated cholesterol has been linked with more plaque formation. Okay, so in terms of cholesterol, we don't test for cholesterol if someone comes in with chest pain. We're doing an ECG, we're doing troponins. Okay, so just see cholesterol as a risk factor, just like smoking is a risk factor, or sedentary lifestyle is a risk factor. In general, we like to see total cholesterol less than 200 milligrams per deciliter. The LDL, so low density lipoprotein, which is a portion of the cholesterol that we can call bad cholesterol, it is typically less than 130 milligrams per deciliter. That's where we like to see it. HDL, which is termed good cholesterol, so an elevated HDL is actually beneficial. It's been shown to reduce the incidence of atherosclerosis. Okay, and we usually like to see that greater than around 45 to 55. So 45 in males, we want to see it greater than that, and 55 in females. Okay, so just note, HDL, good cholesterol, I want to see it high. LDL, bad cholesterol, I want to see it low. Triglycerides are also a risk factor, and when they're elevated, they're also a risk factor for atherosclerosis. Okay, so don't get confused here. Cholesterol is just for long-term risk of atherosclerosis. Cardiac enzymes is to look at today. Has there been a heart attack today? Okay. Okay, a transthoracic echocardiogram is just what it says, transthoracic, so we go through the chest. And it's a probe that goes on the chest, so an ultrasound probe, and we're looking at the chambers of the heart. We're looking at the pumping of the heart. We can see the valves with an echocardiogram. And we can see if someone's had a previous heart attack because that portion of the muscle isn't pumping anymore. Okay, so all kinds of information can be obtained with an echocardiogram. The size of the chambers, what the valves look like, the strength of pumping of the heart can all be used with a transthoracic echocardiogram, and they're easy to get, right? So typically it takes about 45 minutes to an hour to do this test. They're typically lying on their back, and then they roll over to the left side to bring the heart really close to the left chest so they can get a good view. Okay, what about a transesophageal echocardiogram? So same thing, we're getting a view of the chambers of the heart, of the valves of the heart. We can look at the pumping of the heart. We can look for blood clots within the chambers, say such as in atrial fibrillation. The one advantage of this is that it gets the probe really close to the heart. How do we get that close to the heart? You have to swallow the probe in your esophagus. So the probe goes into your esophagus, and right in front of the esophagus, once we get to a certain level, is the heart. So it's just a close-up view. Okay, so we can still look at heart failure, so the pumping of the heart. We can get really close views of the valves. We can look at clots in the atrium or the ventricles. So really it's the same thing. It's an ultrasound of the heart, right? We just want to get a much closer view. It's a bit more invasive though, because the probe has to go into the esophagus. So typically these patients need to be NPO prior to getting this, so they don't vomit while this probe is going into their esophagus. Okay, so there's different types of stress tests. So what's a stress test? Well, it's going to be either an exercise stress test, where we're going to have a patient go onto a treadmill and get them to walk faster and faster and faster while they have cardiac monitor leads on their chest. And they have to typically reach a certain heart rate, a maximal heart rate for their age. And we're looking for changes on the monitor that may indicate a blocked coronary artery. Okay, so as we stress the heart in terms of getting the heart rate up faster, sometimes we can see changes on the monitor that may indicate that there's not enough blood flow in the coronary artery. So for example, angina, we may diagnose unstable angina, or some arrhythmia may occur while they're on the exercise stress test. Okay. So how do we do this? Well, they're going to be walking on a treadmill, right? So we usually advise them to wear comfortable shoes and clothing for the stress test. Now, many people can't do an exercise stress test, either for, say, they're very elderly, they have osteoarthritis, they can't walk for that long. So there's many reasons why someone can't have an exercise stress test. So instead of getting them to exercise on the stress test, we can inject them with some kind of a stimulant to get the heart to speed up. So there's medications such as dipyridamole, adenosine, dobutamine. They're going to get the heart rate up. Okay, so it basically mimics an exercise stress test. They just don't have to exercise. Okay, typically patients are going to fast 2 to 4 hours before the procedure. They're going to be requested not to smoke or take caffeine or alcohol prior to the test. Again, they're attached with monitors, with leads, that go to a monitor to look while they're being injected with these medications to see if there's any changes on the ECG that we'll talk about in an upcoming module, to see if they have arrhythmias or if there's changes on the ECG that show that there's potentially blockage in the coronary arteries. Okay? So after that procedure, the patient will be monitored because they've been injected with a stimulant drug. Their blood pressure will be monitored, and then a report will be generated from the stress test. Okay, so there's exercise stress testing, and there's stress tests that we can obtain with injections of medication. Okay, let's just talk about invasive hemodynamic monitoring, meaning we have to put a central line in or an arterial line in to get very accurate readings of what's going on in different parts of the venous system, or the right side of the heart, or the arterial system. Okay, so these are typically in very sick people. Okay, we don't do this routinely on patients that are coming in unless they're critically ill. So say someone has severe heart failure, or they have, say, acute respiratory distress syndrome, and they're in the ICU. We often like to monitor the pressures going into the right side of the heart, and also monitor minute-to-minute blood pressures. So we need catheters that are inserted in or as a central venous monitoring, okay, or central arterial monitoring. So they're invasive, okay. So what can we monitor? So let's say we put a central line in. So whether it's the internal jugular vein in your neck, somewhere where there's a large vein, what can we monitor? Well, we can monitor just the central venous pressure. So that's the pressure that's coming back to the heart. Okay, central venous pressure. What else can we monitor? Well, we can put a probe in the pulmonary artery, and we can see what the pressures are in the pulmonary artery that the poor right ventricle has to pump against. A pulmonary artery wedge pressure is just a probe that goes further into the pulmonary artery and it wedges into one of the smaller vessels. Okay, so pulmonary artery wedge pressure, that's all it is. So these are all ways of just getting values of pressure from the right side of the heart. Okay, and we like to know that because someone who's critically ill will want specific pressures on the right side of the heart, and we can adjust that with medications and with IV fluids. Okay. What about a pulmonary artery catheter? Okay, so that's going to be a catheter, again, that goes into the pulmonary artery. Okay, so it came in from the right atrium, right ventricle, and was put in to the right, into the pulmonary artery to monitor pressures, right? And it just gives us a good idea of how much IV fluids do they need, how much potential vasopressors, so stimulant drugs for the heart, will they need. Okay, so just gives us lots of information. Okay, what if we want to measure minute to minute or second to second arterial blood pressure? So that would be an arterial line. So typically done at the wrist or the femoral artery. So the radial artery at the wrist or the femoral artery. And this is going to give us minute-to-minute information on the systemic arterial blood pressure, okay? And sometimes we need that in critically ill patients, just to monitor what their blood pressure is very, very frequently, compared to just using a blood pressure cuff. That doesn't give us as accurate a reading as an arterial line. Okay, so angiography is really just the study of a vascular bed, right? So an arterial vascular bed. So if we're doing a coronary angiogram, well, we want to put dye into the coronary arteries and see the anatomy of the coronary arteries and to see if any of them are blocked, okay? If we're doing a cerebral angiogram, we're looking at the arteries of the brain. A renal angiogram, arteries of the kidney. Okay, so we can do angiograms all over the body. We can do angiograms of the leg, looking for a blockage in an artery that's perfusing the leg. Okay, so I'm not going to go into the procedures and post-procedures and all that, but just understand what an angiogram is for. We're looking for potential blockages in arteries. Okay. I know there's a lot of considerations and intra-procedure and post-procedure. I'll leave that part for you, okay? Let's just talk a bit about some complications of an angiogram. Okay, so for a coronary angiogram, they have to go into an artery, okay, whether it's at the wrist, so your radial artery, or at the femur, so the femoral site, and they thread a catheter up to the heart, and they spray in some dye into the coronary arteries, okay? And they have a catheter there. Okay, so what's the potential complications of having a coronary angiogram? Well, the artery could be injured. One of the coronary arteries could be injured, and what's called arterial dissection, where the wall of the artery dissects. And what can happen there is when blood gets behind the inner wall of the coronary artery, it starts to make a false passage, right? And it's going to occlude the coronary artery because the blood is dissecting into the wall. It hasn't perforated right through the wall of the coronary artery, but it's dissected within the wall, so it's going to compress the lumen, and that can lead to a myocardial infarction. So if there's aortic dissection, sometimes they have to quickly go on to surgery to repair the arterial dissection. Okay? What's the other possibility is that they could perforate through a coronary artery, and that could lead to cardiac tamponade, because now you have blood leaking into the pericardial space. You can get a hematoma at the insertion site, so at the wrist or at the feet, at the femoral area. A hematoma can form. So typically we monitor those sites. We put pressure on those sites to prevent hematoma formation. Okay. You can have allergic reactions to the contrast media. So anyone can have allergic reactions if they're getting it for the first time, where they're having basically an anaphylactic type of reaction, right? Chills, fever, urticaria, wheezing, tachycardia would be common signs of an allergic reaction to contrast media. Okay. Embolism. Well, okay, so if you're in the coronary artery and you're opening up a plaque or you're spraying some dye in, well, a piece of the plaque could break off and go further down the coronary artery, and that can lead to blockage of the coronary artery further down, and that could cause a myocardial infarction, right? Restenosis of a treated vessel. Well, if you're in the coronary artery and you open it up and sometimes put a stent across it, that whole area could restenose, could reblock up, right? So there's always a risk for that. Retroperitoneal bleeding is in the abdomen, so when they're putting the catheter into the femoral artery as opposed to the wrist, so it's not going to happen with the wrist, they could puncture the artery. And where will the blood go? Into the retroperitoneal space. Okay, so typically patients will develop hypotension because they have an arterial bleed in their abdomen, and flank pain. Okay, this is an emergency because an artery has been punctured in the abdomen. Okay, so pretty significant complication. Acute kidney injury is going to be from the contrast media because the contrast media can be nephrotoxic. Okay, so typically all they need is lots of oral fluids, lots of IV fluids, and we monitor the BUN creatinine, which is the function of their kidneys.